there are barriers to treatment. Negative attitudes, probably the most. I mean, I've had so many patients who have eventually joined a methadone treatment or an opiate agonist treatment program only with great hesitation and only after a long period of hesitancy, only because of the labeling, the branding that will come with that. So that is one of the barriers of treatment. And the negative attitudes run throughout society. Interestingly, physicians are guilty of this as much as anybody, although one would expect that physicians, nurses, healthcare workers would be informed and educated. It's not always the case. Social services, for example, I've had Children's Aid Society workers who have deemed a mother unfit simply because she's on methadone. The hypocrisy in this, or the ridiculous aspect of this, is that oftentimes this is a patient who had been in horrible straits while abusing drugs on the streets and would have been an unfit parent, for example. But once entering the methadone program, once entering an opiate agonist treatment program, they basically regain their stability, regain their lives, regain their sobriety, and suddenly their children are apprehended. So this is one of the negative attitudes and biases that has to be dispelled, and that's why we're finally, or very shortly, going to discuss the myths. I see I'm talking way too long, so I'm going to rush through this a little bit. We did talk about addiction as an illness, and certainly looking to addiction and comparing it, for example, to diabetes. Where the medication adherence and compliance is very low, where medical intervention is very common. That medical intervention might be lifelong. That's not only an issue with diabetes, that's an issue with addictions as well. And addictions will have relapsing remitting courses. There is a genetic predisposition to addiction, as we said. There is an error, or there is an individual choice factor at play, obviously, here. A lot of patients will unfortunately make a number of poor choices which allow them to become physically dependent, and only then will the addiction develop. The illness can lead to major harm, including death in patients. And interestingly, prevention and treatment are both possible and quite common in addictions as in diabetes. I'll skip that here. Quickly, what goes on at our clinic basically is patients will discuss their various problems. They'll oftentimes, well, not often, they should undergo a physical examination prior to starting the program, and basically they're monitored. So I will spend the last couple of minutes of my yapping to discuss the myths, and we can then take your questions. So let's talk about the myths. First of all, OATP, as opposed to OATC. OATC, Ontario Addiction Treatment Centers, which is where I work, but OATP are opiate agonist treatment programs. One of the myths, oh my God, you're on methadone, you must be a heroin addict. And of course, that's becoming less and less of a myth. People are well aware of the OxyContin problem, but the bias that comes from that is, as I said, one of the barriers to treatment. So the opiate agonist treatment programs are not just for people who are heroin addicted or for people who are injecting drugs. These are available and should be entertained by all people who have become addicted to opiates. Myth number 2. Patients in opiate agonist treatment programs become addicted to the methadone or Suboxone. And again, that is something that must be dispelled. How many times a day, I can't tell you, I hear the issue of, oh, you're trading one addiction for another. A person who is in a methadone treatment program on methadone is dependent upon methadone, yes. If they were to suddenly stop the methadone, they'll feel withdrawal, they'll feel lousy, they will feel miserable, and they'll want to shoot someone or themselves. But a person, although dependent, is not addicted. People who are doing well in the methadone treatment programs, they're not committing crime in order to buy medicines. They're not lying to friends, family, and healthcare workers in order to obtain drug. They're not risking their health by injecting or using multiple medications. So patients who are in a treatment program, although dependent upon methadone or Suboxone, they are not addicted to. So one of those common myths that people are trading one addiction for another must be dispelled. The next myth, patients in treatment programs should be limited to a well-defined treatment period. It's amazing how often I'll hear this as well. Well, when do I get off the program, doc? Or even from, family members or healthcare workers, how long is this going to take? Well, it's going to take as long as it's going to take. Using the diabetes analogy again, I have a lot of patients who, when told that they've become diabetic. They have set about to correct a lot of the lifestyle ills that allow them to develop that diagnosis. They will eat better, they will exercise, they'll lose some weight. And these are folks who, even if prescribed medications, might get off these medications and never need them again. The same pertains to addictions. A lot of patients with addictions will go into an addiction treatment program, whether it be with use of medications like Methadone and Suboxone, or whether they go through treatment inpatient. Whatever the program might be, there are patients who will be successful and will be able to live their lives, hopefully for the rest of their lives, without the use of drugs and also without the use of the supports in the community. That said, there are many people who will unfortunately require treatment for a lifetime. So there's no well-defined treatment period for patients in opiate agonist therapy, and that's something that, again, another one of those myths that need to be dispelled. The fifth in the list here is that the opiate agonist treatment programs are a drain on provincial coffers. This has been misproven over and over again. It costs 10 times to incarcerate an individual what it would cost to keep them in a treatment program. The medications are relatively inexpensive. Yes, the bill to OHIP could be substantial, given things like regular urine screening, frequent clinic visits, etc. But again, the cost to general society has been proven over and over again to be a small fraction for patients in treatment versus patients who are not in treatment. And the final myth, and it's not exactly a myth, but it needs clarification, that methadone and Suboxone are dangerous. Yes, in the wrong hands, they're dangerous. At the wrong dose, they're dangerous. The same way insulin in the wrong hands or the wrong dose could be lethal. But methadone and Suboxone, when used properly and under the confines of a registered treatment program, are well studied. Methadone, in fact, is one of the most well-studied medicine of any drug out there. Methadone and Suboxone are very well studied, and when used properly and when used appropriately, are no more dangerous than many of the medications that we take for granted on a day-to-day basis. So, conclusions. A patient in treatment will reduce the harms associated with illicit drug use and the lifestyle issues around that. Again, not a surprise to anybody who is working within that field. There is a movement towards lifelong abstinence. We work in a harm reduction model, but the number of patients who achieve long life abstinence is quite substantial. It is a cost-effective treatment strategy, as discussed earlier. And if we approach addictions as we do with many other chronic illnesses, it'll allow us to treat our patients with more respect and also more appropriate therapeutic interventions. So